you very much. It's a great pleasure being connected with you. So I think we can start this first session dedicated to the decision criteria and bone augmentation procedure. What we are going to join in these 2 days basically is how to improve the predictability of our bone augmentation procedures, looking the biology behind the bone augmentation to understand how our surgical performance can influence positively or negatively the outcome of the regeneration. We are going to talk about how the digital technologies can help us to managing bone harvesting, for example, and planning of the bone augmentation following the shell technique as proposed by Curie. And we are going to focus on the soft tissue management, how we can elongate the flap, how we can obtain a real predictable primary wound healing of our surgical procedures, so to improve the overall predictability of the treatment. So we are starting now talking about the biology around the bone augmentation and in strictly relationship with what we are doing. And now we are ready and we start. And obviously, when we are looking to implant therapy and the predictability of the implant therapy and the area of comfort that we are working in, when we are in an optimal clinical condition, meaning that we have the bone, we have the soft tissue in the right position in terms of volume and keratinized tissue, it's obvious that placing the implant three-dimensionally is the only thing we have to take care. So, and we know perfectly from the literature how we should perform this type of procedure in terms of distance from the neighboring teeth, inclination of the implant related to the future prosthetic rehabilitation, and obviously implant shoulder relationship to the outside contour. So we have strict indication from the literature how we should perform this implant placement. And since we know the rules related to implant placement, then the expectation in terms of results outcome is very high, is very predictable, both in terms of bone function and aesthetic result. So we are really in a comfort zone working in this type of scenario. And anytime we are working or we are engaging a case where these factors are there, we are really working with no stress, which is something very important, because the stress usually from a surgical point of view is at the base of a mistake, of not evaluating the correct way what we are doing. So working without stress is fundamental. But it's obvious that if we are working without stress in a perfect scenario, what about this case? What about when we are missing anything? When soft tissue is not in the right position, bone is not in the right position, and for sure, the outcome of the regeneration will be fundamental to define the chances to have or not to have osseointegration in this particular case. And it's obvious that the patient is coming to us asking a solution for the problem that is clear also to their eyes. So in these cases, it's not just a question to generate a volume, to fill a gap. We need to have a new bone formation in this area. Otherwise, implants cannot be placed and osseointegration cannot happen. So we need not just the volume in this area, we need a vital tissue, and the predictability in regenerating this volume is questionable, because it's obvious that any one of us in front of a scenario like this is asking himself if it's possible to regenerate this volume, how risky is to go through the surgical therapy, and how much predictability can we present to the patient. And it's like a foggy street. We know that something can be done. We know that we may be able to regenerate bone, but we are not really sure which will be the outcome, how long will be the treatment, how many surgeries we need to treat this type of deficiency. And it's obvious that these kind of uncomfort from our side is for sure felt by the patient too. And this is not the best starting point for a surgical treatment. So we need to take out the fog from our surgical plan, from our surgical therapy. And what I hope to do in these 2 days is to make this trait quite clear, just to improve strongly the predictability of the bone regeneration, starting from the biology of the bone regeneration. Because if we know the rules of the game for regenerating the bone, then we can really improve the predictability, because we are doing what is biologically expected. And many cases are nowadays coming on my offices with really dramatic starting points, because we are treating also nowadays defect not generated simply by teeth, but the defect generated by failure of implant treatment, meaning that implant has been placed maybe 10 years ago. They went through perimplantitis, and they are ending with a strong distraction of the alveolar process. So we are really in a critical situation with huge deficiency of bone, not just in the vertical direction, but also in the mesiodistal direction, like in a case like this. And we have no other options than going through a bone regeneration procedure to place new implants if a fixed rehabilitation is required or expected by the patient. There is no chances of short implants or teethal implants in cases like this, because there is no room even for this type of solution. So which is our answer to the patient coming in our office and asking for a solution? Because the first thing usually they ask to me is not discussing on the type of therapy or type of surgery I propose to them, but the first question they are asking to me is going to work what you are proposing me? How predictable is this treatment? And this is more important to them than the expenses of the treatment. So the first point is, can these work? And I can tell you, these can be really predictable if we know the rules of the game. So the predictability is the strongest point and should be our roadmap to take any type of decision during our treatment and surgical treatment. Because anytime we see a defect, usually is not a problem in terms of diagnosis. It's not a problem of defining if the defect is vertical, horizontal, or a combination of these two types of deficiency. Anytime we can make a walks-up, so we define where the future tooth is going to be placed, then it's quite easy to understand where the implant shoulder should be, and as a consequence, where the bone must be to make reliable that type of final result. And this could be in maxilla or in the mandible as well. So the point is not a diagnosis. We are not failing in diagnosis usually. We are failing in evaluation of the deficiency, in the choice of the material, in how we are performing the surgical procedure. And it's obvious that when the aesthetic area is involved, when the area that is involved must be or is in the visible area of the smile line of the patient, then obviously it is not just a bone point, but is a soft tissue point too. So we must integrate our restoration with the natural dentition present in the mouth of the patient. Because usually what we are working or where we are performing bone augmentation procedure are partially edentulous patient, meaning that the remaining teeth are going to be maintained, and we have to bring our therapy and our new restoration in harmony with the existing dentition. And so we don't need just to regenerate, to create a new bone shape, but we must also look to the soft tissue. Then the stability obviously is a crucial factor for the successful outcome. But when you are looking to the literature, and the last literature even from 2019 is not differing from these numbers, the complications rate is very high. So if I'm approaching to a patient and I'm proposing a bone augmentation procedure and I have in my mind these numbers, I should be worried about the successful of my regeneration, because we have around 10% complication for the horizontal augmentation and around 12 to 30% of complication for the vertical bone augmentation. So that is absolutely huge numbers if you're thinking from a clinical point of view. It means that every 10 patients treated for vertical augmentation, we have a risk to have between 1 and 3 failures. So we have 3 patients that must be retreated. And it's obviously retreatment is ending in more biological costs, more treatment time, more economical costs that usually are going to affect obviously the practice business. So there's negative effect on patient side firstly, and on the office on the other side. So it's really important that these numbers are lower, much lower than in the literature is reported. So once again, we must know the rules to improve the predictability. And what we are talking today is the biological diagnosis in bone grafting. So which are those factors that we have to take care to improve the outcome of the regeneration, how the surgical technique may affect the final result, meaning that sometimes our surgical choices can be favorable for the bone formation, and in some other cases are not appropriate choices to improve the predictability of the result, even if we think to perform the surgery perfectly, even if we have a perfectly primary bone healing. Then we should ask ourselves before starting, which is the surgical goal of our treatment, why we are performing a bone augmentation, because the answer to this question is going to have a strong effect on the stability of the grafted area. And we must understand that materials behavior are different depending on the material we are using. So the graft material choice is strongly related to the surgical goal of the treatment. And we are going through these 4 points to improve our choices criteria, and at the end you're going to see to improve the outcome of our regeneration. So this will be the flow of my lecture. And if we are working on vertical or horizontal augmentation, we may have many chances or many ways on how to perform this type of augmentation. And the literature is telling us that we have really different flap design, different graft material, different techniques, from membrane, from titanium mesh, from blocks, from Curie's shell technique, and everything seems to work looking at the literature. And it seems from such a point of view that these techniques are looking or are following different biological principles or different biology, but it's not. At the end of the surgery, once we have closed the wound, the bone formation will follow anytime the same process, because in the mouth the bone formation is following the intramembranous ossification process. So doesn't matter which type of technique you're using, the bone formation will follow just one way. So the biology for bone formation in the mouth is just one, and it's an intramembranous ossification. That's it. There are no other ways in the mouth to have bone formation. And what we need to have the intramembranous ossification process, we need a well-organized blood clot. This is the real graft material that we must have in our wound at the end of the surgical procedure. And the blood clot must fulfill the area that we want to regenerate. If the blood clot is compromised, or if the blood clot is not filling completely the area, or if the blood clot is lost during the healing, then the wound process is going to be stopped or reduced. Think about what is happening when we have a dry socket, meaning that when we extract the tooth, when we are waiting firstly for the blood clot formation, then we leave the patient, left the clinic, and after 3 days the patient is coming back complaining with pain. And usually what we are seeing is an empty socket in that area, dry socket. And which is the treatment in that cases? Is to simulate at the end a new extraction, meaning that we are damaging again the recipient side, regenerating a new blood clot so that the wound can start again. And why is so important the blood clot? Because the blood clot will be the frame for the provisional matrix formation, which is the first tissue that we are going to have in the wound area, which is a very dense collagen tissue rich in collagen type 1 and a lot of blood vessels. And this collagen, this provisional matrix, is going to be the framework for the ossification, and this ossification is called woven bone formation. And it's woven bone because the collagen fibers that are going to be embedded in the calcification process are randomly placed because are those fibers related to the provisional matrix. And then the woven bone will be reorganized in lamellar bone formation, where the collagen fibers are parallel placed. So we are organized to get the best function and structure to the bone. So the lamellar bone will form where the woven bone has been previously formed, and the woven bone is formed where the provisional matrix has been was replacing the coagulum. So everything starts with the coagulum, and the coagulum dimension is fundamental for the new bone formation. Now, from a surgical point of view, we should know what is needed to the body to perform, to go through the provisional matrix into the woven bone formation. Because if we know what is needed, then our surgical procedure is supposed to recreate a perfect scenario where the biological process can run. The surgery is not performing the regeneration. The surgery is just creating the environment where the regeneration will run. So we need to know what is needed. And what is needed? We need vascular support, abundant vascular support. We need inductive factors, meaning BMPs in the area, not just general wound factors that what we can obtain, for example, with PRGF or PRF, but we need specific bone-specific proteins that are the BMPs, and mechanical factors, meaning that we need stability of the environment. We need a protected environment from disturbances during the ossification process. Otherwise, if we don't have the mechanical right environment, the provisional matrix will be the final result of the wound regeneration, meaning that we are going to have fibrous tissue instead of a bone tissue. Why is important angiogenesis? Angiogenesis is fundamental because there is a strong, close, spatial and time correlation between angiogenesis and bone formation. If we don't have enough blood vessel supply, we are not going to have too much bone formation, because the cells that are going to be transformed into new osteoblasts are coming from the blood vessels, are perivascular cells. Even if the vascular support is coming from the soft tissue, these perivascular cells may turn into osteoblast and not necessarily into fibroblast. Everything will be depending on the environment, on the local environment that these cells are going to find in the wound area. Then inductive factors. Inductive factors in the bone are embedded in the osteoid matrix, meaning that are the organic parts of the bone. They are locked into the mineralized tissue, and they are unlocked during the first inflammatory phase post the surgical procedure, where the mineralized part is going to be demineralized and the osteoid matrix is going to be exposed to the wound area, and these osteoid matrix rich in BMPs will represent an inductive factor for the mesenchymal cells in that area that are going to be transformed into new osteoblasts. And being transformed into new osteoblasts, these cells are going to produce themselves new BMPs, involving in the differentiation neighboring cells, so that we have in a sort of positive circle where osteoblasts are inducing, not just producing new osteoid matrix, but also influencing the neighboring cells to be transform themselves into new osteoblasts. So this is the only way how we can influence the osteoblast differentiation, through inductive factors. Must be bone-specific factors. And then the mechanical factors. Mechanical factor, it's obviously represented by the shape of the defect, because it's a mechanical protection of the wounds, of the coagulum, and if we are in the right mechanical environment, we are in the right influence of the inductive factors, and we have the correct blood supply in the wound area, the bone formation will happen alone. And here you can see a clear example, but we have in the literature papers by, for example, Lundgren, showing that in the sinus you may just create the space, placing an implant, and to have a stabilized coagulum, and you can have bone formation in 4 months. So we don't need to think anytime that we must place something in that space to have bone formation. So how we can define then if a defect is critical or not? Because we know that for the bone formation we need to have the blood supply, we need to have the inductive factors, we need to have the mechanical factors. And you have to think about these 3 factors as a sort of chair with 3 legs. And anytime you take out a leg, the chair cannot stand anymore and it fell down. It means that we must have all 3 factors simultaneously in the wound area to have a predictable bone formation. Otherwise, the provisional matrix will be the final result of our regeneration. Now, how critical is the defect? It depends on the number of walls and basically on the distance between the walls. And these 2 factors are the most important factors to evaluate clinically and pre-surgically how difficult will be the regeneration in that area. Why I'm telling this? Because we have many studies related on wound healing and bone formation. For example, in GBR scenario like this paper by Schenk in '94, where just coagulum was placed as a graft material in a protective defect with a PTFE membrane, and where clearly is described that from each wall of the defect, a bony heel will grow towards the middle of the defect. And in this case, you can see 3 walls, 1 mesial, 1 distal, and 1 on the bottom, the floor of the defect. And we have 3 heels growing towards the middle and reaching themselves in the middle, performing the bone formation and regeneration. It's a sort of wave starting from the walls of the defect. And why starting from the walls of the defect? Because close to the walls of the defect, we have the vascular support, we have the inductive factors related to the bone close to that area, and we have the mechanical protection given by the wall of the defect itself. So if these factors are maintained during the overall process, then we have these heels growing towards the middle. If in some time or during the wound maturation there's a reduction in vascular support, there is a reduction in mechanical stability, then these bone growing will stop. And then we are going to finish with a partial regeneration and a fibrous tissue in the middle or on a distance in that defect. Then the other important point has been demonstrated in this PhD work by Gustavo Avila in 2010, talking about the sinus, which is, from a clinical point of view, a different scenario compared to the GBR we have talking about now. But in the sinus, what is going to happen is exactly the same, meaning that from the walls of the defect, the bone regeneration will start. And the two main sources in the sinus are the medial and vestibular walls. And if you are increasing the distance or you are reducing the distance of these walls, and it's obvious that is an anatomical condition, then you are going to see an effect on the final results in terms of bone formation. And if you have closed walls in the sinus, then you're going to have much more bone formation compared to a sinus where the distance is increased, because from those areas the bone is growing and is growing towards the middle. So if you are increasing the distance, you need more time and you need more stability of the three factors: vascular, inductive, and mechanical, for a longer time. So it's going to be more risky, the regeneration, or less predictable. So when you are looking to a defect, we should look on the distance of the walls. And this is the same thing that is going to happen in a socket. If you extract a tooth and you are looking the healing, now just in this paper by Cardaropoli, talking about the mesial distal section. We're not talking about the buccal at this stage, but the mesial distal, what we are going to see is that the bone is following exactly the same dynamic. So we have the bone growing from the walls of the defect towards the middle. And we have firstly the coagulum formation, then the provisional matrix formation, and then the woven bone formation, like different waves going from the walls of the defect towards the middle. And it's obvious that if you are looking here and you're looking particularly the left histology, you see that the middle part and apical part, we have already a full field bone formation of that area. And this is just related to the fact that the distance is smaller compared to the coronal part, where the distance is increased due to the anatomy of the root, and we need more time to get the bone formation in that area. But if you are looking at CBCT of a patient where a tooth has been extracted 2 months before, we are going to see exactly the same radiological image as we have seen in the histology of the dog. So we have the walls of the defect, we have the bone formation running from the walls of the defect towards the middle. And if you want to look in a clinical case of the fractured tooth, we should not stop ourselves on analysis of the buccal lingual dimension, because which information we are going to obtain here? We are going to obtain the information related to the fact that we are probably missing, or we are going to lose, the buccal wall due to the fact that we have a very thin layer of bone that is related to the periodontal ligament and not related to the alveolar process. But we should look also differently, and looking from a regeneration point of view, the two main walls for the regeneration in this case are the mesial and distal walls. So the distance between these two walls is 3.3 millimeters in this case. It means that is a really small deficiency in terms of bone regeneration. And we may consider to perform this type of approach even without placing any type of graft material, and even not without placing any type of graft material and just giving the stabilization of the coagulum, we may see no or very, very limited alteration of the buccal side. In this case, the implant has been placed using a dynamic navigation process. So it's basically a guided surgery, but this guided surgery is going to be performed without a surgical guide, but with the real-time control of the relationship between the drill, the bore, and the implant insertion in relation to the surgical plan. And we know from the literature nowadays that this type of approach is a very accurate approach, comparable to the freehand approach, to the guided, traditional guided with surgical guide approach, and with much more accuracy compared to the freehand approach. So we are not following physically a surgical guide, but we are anyway perfectly under control for the implant placement. But in this case, once again, no graft has been placed, so just the guarantee, we guarantee the presence of the coagulum inside the alveolar gap and socket, and we need obviously to adapt and place a temporary crown to even improve the protection of that coagulum. This is the situation after 1 week, after 3 weeks, and 8 weeks, where we have a perfect adaptation of the tissue, and this is after 4 months with a fantastic shape of the contour of this alveolar crest, and we have really a stable outside contour compared to the starting point, with a minimal amount of changing in shape, which is clinically cannot be seen because it's really minimal. But this is thanks to the fact that the distance between the two walls of the defect are very close, so the predictability of and the stability of this environment is very, very high. But if you are changing the environment, even talking again about post-extraction side, we are changing completely the deficiency. If you're talking in this case, we are the double distance from the starting point, and we cannot expect no alteration of the buccal side because the gap is bigger, the stability of that environment will be changed, and we must then take care about that stability. So in this case, you see that we have a collapse of the tissue immediately after tooth extraction, and we have obviously to place the implants correctly. But here, what I want to focus and stress is that we are going to change the dimension of the defect, and even if the dynamic of the healing is similar from bone formation point of view, the shape of the final shape of the crest will be different because the different is the defect. And cannot be compared to the other case. So we are going to place the implant, we are going to fill the gap with the bovine bone, and then we are going to place a connective tissue, and this is the result after 4 months. So we have improved or given the stability to the tissue, but improving the stability of that coagulum with a slow resorbable material to obtain stable tissue. And this is after 4 months with a very nice shape of the tissue. And I want to underline one important aspect, because anytime we are talking about aesthetic and around implants, we have to remember that we have 2 different compartments where we have to work. One is the bone, which is related to the rough part of the implant, and one is the soft tissue area that is affecting the emergence profile of the crown. So we must work anytime on both sides, hard tissue and soft tissue. Even when the cases are going to increase their dimension in terms of defect, any treatment is always involving bone augmentation procedure and soft tissue augmentation procedure. So how critical is my defect? Number of walls, again, and distance between walls. Because if I look this, I can understand how difficult will be the regeneration. So number of walls, distance from the walls, and mechanical protection. That is the important point. Because mechanically, or we may take decision in terms of how to perform the surgery to improve the mechanical stability of the environment. And we are going to see how we can compensate the reduced number of walls or the improved distance from the walls, getting a better outcome, a better predictability of our results. So how critical is the defect and how we are going to get the surgical choice. And from my point of view, the defect is going to drive my choices, meaning that if the defect has a very high predictability, because we have walls of the defect, we have a reduced distance between these walls, and we have a mechanically stable environment, obviously my choices will be related to this scenario. And on the opposite, I will have different choices if the scenario will be changed, meaning that we'll be more critical, we will have more distance, we are going to have more or less walls involved and less mechanical protection. So but we have to understand that the choices we may take during the surgery can affect the final result. And how this is going to happen can happen for different aspects, can happen for vascularity, for example, and can happen also for the inductive factors, and can happen also for the mechanical stability of the environment. But now we are focusing about vascularity. Now, why is important vascularity and how we are going to affect this? We know that vascular support must be important, must be three-dimensionally well distributed in the grafted area, and must be fast, because this vascular support will support the bone formation, and the bone will form just around the new vessels network that is going to be developed in that area. Now, if you are looking on the bone integration process, on the implant integration process, meaning that we are going to have a implant placed in a healed site, so native bone, no grafted bone. We know from the literature that, and this is an example, that the cortical compartment and the trabecular compartment are going to have two different time and quantity of bone formation, depending basically on how the vascular support will developing during the first healing phase. And you can clearly see in this histology that we have two different architecture on this implant, meaning that in the coronal part we have a very dense bone, we have small empty spaces, small lacunae, which is the center of an osteons where the blood vessels are running. On the opposite, on the apical part, we see a trabecular bone, which is characterized with a less dense amount of mineralized tissue. We have much more empty spaces and much more vessels present in that area. So when we have a wound close to the implant area, we are going to have firstly a coagulum in that area, and this coagulum is going to attract the blood vessels growing in that direction. And what is going to happen basically, that in the trabecular bone, we are going to have bone formation In the trabecular bone, we are going to have blood formation very fast, really very fast, because we have empty spaces between the trabecular. On the opposite, on the cortical bone, we are going to have osteoclastic activity to allow the blood vessels to reach that area. And you see this tunnel open in the mineralized tissue thanks to the work of the osteoclast. But what is going to happen? That this osteoclast activity is going to involve less number of vessels compared to the trabecular area, and needs definitely much more time to allow the blood vessels to reach that area. So we have less blood vessels formation compared in the cortical area compared to the trabecular area, and this is going to have an impact on the new bone formation, which is less in the cortical bone compared to the trabecular area. So why this is important when we are thinking on a bone augmentation procedure? Because the architecture of our graft is going to affect the way the vascular support will grow in that area. And there is a tremendous difference if you are working with particulated bone compared to blocks. Dense block maybe from the ramus area or from the mandible in general, because the block from the mandible is going to be like a wall for the vascular support. We need osteoclastic activity to let new vessels to penetrate into the graft and to bring new cells and new bone formation. On the opposite, trabecular or particulated material will have anytime the space between the particles where the coagulum will be at the beginning, where the blood vessels can develop during the first healing phase quite easily and quite fast. There is a completely different coagulum position. On the particulated material, the coagulum is inside the graft, between the particles. In a block scenario, the coagulum is going to be displaced by the presence of the block, and the coagulum is not in the middle of the graft, but is just around the graft, which is going to be on the periphery of the grafted area. And as we know from the literature, and this is just one of those examples, we know that a block from the mandible, even if it's an autogenous bone, is going to be dead at the time of the grafting procedure and need to be revascularized to get new vital cells inside. And usually when we are waiting between 4 and 6 months, we may have really a poor histological result in terms of graft vitality. And the reason is that we need first an osteoclastic activity to open a channel, to open a tunnel inside the block, bring new vessels inside and new bone formation. But this new bone formation will be just inside this tunnel area, which is few hundred microns inside the bone. So will be a minimal amount of bone formation. And this is related to the fact that the speed of blood grow into the graft material is completely different. In the trabecular bone, spongious bone, or particulated graft material, the speed of vascular support is 10 times faster in developing compared to what is going to happen in a cortical bone. So if you are grafting a 4 millimeter thick block from the ramus area, which is cortical, mainly cortical bone, blood vessels will take around 3 months to penetrate into this block and to perform 4 millimeter growing. On the opposite, if this material is completely particulated, these 4 millimeters can be completely managed in a little bit more than 1 week. So the final result is completely different. And looking to this schematic view, and thinking that this blue or light blue is our block, cortical bone, we think an osteoclastic activity will start, a channel will open with different arms, and new blood vessels will grow in that tunnel, and new bone formation will happen in those hundreds of microns opened by the osteoclastic activity. So we have new bone formation, but the rest of the block is a non-vital bone. And indeed, if we are looking back to the histology of the paper by Zerbo, you see a section of these tunnels. So you see the circle, the dot circle, that is the tunnel opened by the osteoclastic activity, which is at the end the osteon formation. We see the blood vessel in the middle, you see the new bone formed and the osteocytes indicated by the arrows. But this is the area of the vital bone, and all around, outside the area of influence of that tunnel, we have still non-vital bone. And it's important to have a vital tissue because we know that the osteocytes will be responsible for the renewal of that bone, meaning that the osteocytes are the first actor for activating the osteoclastic activity, for the new bone formation, for the renewal of the structure of the bone. If you don't have osteocytes in this mineralized tissue, we have a strong risk to have resorption during the functionalization of this bone and not volume maintenance, because there's no cells able to activate the renewal process, the physiological renewal process of the bone. So it's very, very important that we are leaving space in the bone for the graft, for the coagulum, and for the new tissue formation. And if you're looking to this paper, it seems at the first view something that is exactly the opposite of what I have said. In this paper, Rocchietta and the other authors compare in a GBR scenario block versus particulated material. But in this study, they just analyze the space between the threads of this osteosynthesis screw in the particulated area and in the block area. So they are not considering the block itself, and they are not considering the particulated material itself. And if you're looking strictly in the space between the screw and the graft material, you see that we may have more bone formation in the block area compared to the particulated material. But if you are looking inside the block and inside the space of the particulated material, we have a completely different result, and we have no bone formation at all in the block area, as you can see here in this histology, where you indicated BB is the bone block, and there's no vital cells in that area. So this is mineralized tissue, but with zero vitality, and the new bone will form just in the space, in the empty space left by the preparation of the hole for inserting the osteosynthesis screw. And if you are looking on the particulated material, you see a lot of bone formation in the particles area because we have empty spaces. So in this paper, we see again the enormous effect of the macroarchitecture on the new bone formation. So using a bone block, a cortical bone block from the ramus or from the chin area, as it come out after the harvesting, it could be the worst scenario from a vascular point of view and from a regeneration point of view, even if it's autogenous bone. And for example, in this paper, just the opening of new spaces by perforating the block is going to improve strongly the new bone formation and the revascularization process, because in a sort of way we are reducing the thickness of the cortical block by applying perforations and tunnels in these block. So what is going to happen if we are changing the macroarchitecture of the block? Meaning that we are taking cortical bone, we are particulating this bone with a bone mill or bone scraper or other tools. What is going to happen histologically? Histologically, we are going to see bone formation independently on the way we are reducing the or we are changing the macroarchitecture of the graft. We are going to have a lot of bone formation. And what is important to understand is that even cortical bone is going to change the way of the regeneration. So there will be not anymore osteoclastic activity opening tunnels inside the cortical bone to bring the blood vessels inside, but the way the behavior of this particulated bone is going to be like the trabecular bone renewal. So all the surfaces of the particles are going to represent a new surface for bone apposition, and the vascular support will happen very fast because we have empty spaces between the particles. So, what was proposed more than 20 years ago by Fouad Khoury? To take the block, to take the cortical bone harvested from the retromolar area, and to divide this block with the saw extraorally, dividing into two lamina, and then scrape this lamina till reaching the 0.7, 1 millimeter thickness, and collecting particulated material, so that at the end we are changing the macroarchitecture of the graft into something that is, from a vascular point of view, much easier to be revascularized and to support the new bone formation. And it's incredible how much bone we can obtain from the original block. And as you can see here, this is a block from the retromolar area, which is a complete cortical bone of around 3 millimeters or a little bit more in terms of thickness. And once again, this type of management, which takes around 8 minutes, 10 minutes extraorally, is going to be performed with very thin saw not to lose the bone, and diamond disc, not so, sorry. And then you see that we divided the block into two lamina. These lamina are bigger than 1 millimeter, so we are scraping the block, mixing together with some venous blood. You see that we are obtaining very thin lamina, but still very rigid, so the mechanical property of the lamina is still there, and we are reducing the thickness, but look how much bone we are obtaining from that block. So at the end, we started with 3 millimeters, and now we have more than 10 millimeters of bone in thickness to manage the bone augmentation, changing the macroarchitecture of the graft, and this is going to affect the vascular support of these grafts. So changing the macroarchitecture, it means change the way, or to make the vascular support easier. And this is going to happen anytime. Even if we are talking about xenograft block, we should avoid to use dense material, because dense material or very strong corticalized material will not allow a fast vascularization, which is what is biologically expected to obtain a new bone formation. But what is going to happen if I place a membrane? And this paper is going to explaining us that if you are placing a membrane, you are changing the way the vascular support will happen. In this study, a block was placed without a PTFE membrane, and the block was placed protected by a PTFE membrane. Now, the block without the PTFE membrane, so with the block without the membrane, was receiving vascular support from the soft tissue side and from the hard tissue side. So two sources of vascular support. On the opposite, the block protected by the barrier membrane received the vascular support just by the hard tissue side. So has less surfaces for vascular support. And the result is that less surfaces that supporting the new vessels network formation are ending with less bone formation. So placing a membrane is going to change the vascular support and may have a negative effect on the new bone formation. And we try to understand this on a clinical scenario. If you have a defect like this, 11 millimeters in vertical deficiency and 14 millimeters mesiodistally, and we think to place a barrier membrane to protect the graft material, to protect the environment, to protect the coagulum, we must know that all the blood supply will come from the red area in the surgical picture, meaning that that area will be the only area allowed to support the vascular network formation in the grafted area. So, and if you are bringing this on a CAD, in a CAD software, you can calculate this area, which is 138 square millimeters, and this is just specific of this environment, but just to have a comparison between a scenario where we are not placing a barrier membrane, meaning that we allow the vascular support not just from the bone side, but also from the soft tissue side. So we are using 100% of the vascular support possible in that area. And you see clearly that the vascular support areas are completely different if I'm placing a barrier membrane or not placing a barrier membrane. It's obvious that bigger is the defect, bigger will be the discrepancy between these two scenarios. And for example, if I'm working in a GBR PTFE membrane, I'm going to have vascular support just from the recipient side, bone recipient side. On the opposite, if I use the Curie's shell technique where no membrane is going to be applied, the blood support will come from the hard tissue and soft tissue sides, meaning that we have 128% more surfaces compared to the GBR scenario. So what is the meaning of this clinically? The meaning is that anytime, for example, you are taking out a PTFE membrane after 6 or more months, you can clearly see that there's no vascular support or vessels going from the tissue to the grafted area. So this can have a negative effect or not. And if you're looking, for example, on the last papers by Istvan Urban recently published, he said that if you are growing more than 5 millimeters in the vertical direction, you may have a reduction in terms of predictability of bone formation, even if you have a perfect wound healing that is going to be around 6% in the vertical augmentation between 5 and 8 millimeters, but is going to be more than 10% for the bigger defects, more than 8 millimeters. So what he proposed in the last years is to change the macro structure of the PTFE membrane, talking more about a mesh membrane with microperforation to allow a better interaction between the two compartments, where obviously now also the soft tissue side can allow a sort of perfusion or vascular support to the grafted area. It's obvious that a GBR in a sort way, as we know, as a concept of not allowing or completely separating the two environments, is a little bit changing or placed in discussion, but this is how we can manage to improve the vascular support. On the opposite, if you are working with the Curie's approach or anyway with other techniques where no membrane are applied, for example, titanium mesh with autogenous bone, then no membrane is needed and the vascular support will come from the soft tissue and hard tissue, both sides, render more predictable the vascular network developing much faster, and this may affect the final result. Now, what about the perforations of the recipient sites? Are these perforations improving the vascular support on a site? Are improving the final result? Is still under discussion, meaning that we published in 2019 a systematic review of the literature till 2018, and there was really no strong evidence that perforating the recipient side will improve the new bone formation in the grafted area. What we must have anyway is a coagulum. So if you have a recipient site that is not bleeding, we must traumatize this recipient site to improve the bleeding process, because if we have a bleeding process, then we are going to have a blood clot in that area, which is the real graft material. So the message is not that make no sense to make perforation. It makes sense anytime we don't have a recipient site that is bleeding, but is not so. It's not a conditio sine qua non. We have new bone formation, meaning that we may also not perform necessarily perforation, and we are going to have new bone formation anyway. So, summarizing how we can affect the vascular support by our clinical decision. So, remembering that vascularization is needed for bone formation, that the speed and three-dimensional distribution of the new vessels is affected by the graft macroarchitecture. From ideological point of view, the coagulum need no other graft material together, so the coagulum has no barrier for the new vessels penetration. But if we are placing a graft material, we should look to particulated material or spongiostructured bone graft instead of a block graft, because if you are using a cortical bone block graft of any origin, even if autogenous, we are not generating the perfect environment for new blood vessels penetration. Obviously, that using occlusive membrane may completely generate a physical barrier for the vascular support from the soft tissue, or may delay the vascular support from the soft tissue. It depends on the type of membrane we are using, but potentially, if we are not using a membrane, you are let both sides from hard tissue and soft tissue vascular support to participate to the healing process. And then we have still limited evidence that bone perforation of the recipient side generate new bone formation. So, what about inductive factors? How our surgical choices can improve the effect of the inductive factors? Now, if you are looking to the defect, we should look on the geometry of the defect. We should look, as we said, on the number of walls of the defect, because the number of walls of the defect will represent the sources for new bone formation. And we must look also on the distance between the walls. And if you're looking on the cross section of these two mandibles, you may not really understand the anatomy of the defect. So you may think that the defect on the left is much more critical in terms of regeneration compared to the one on the right. But it's not, because the one on the left has 3 walls that are also close each other. So the bone regeneration in that area will be strongly influenced by the BMPs, the inductive factors released by the walls of the defect. On the opposite, on the right side, we have an open defect. We have also there 3 walls, but the distance between these walls is completely different. We have much more distance. It means that we have less effect, less positive effect given by the induction of these 3 walls in relation to the regeneration. So if I need to perform something surgically to help the predictability of the regeneration, I should understand firstly that these 2 scenarios are completely different from a regeneration perspective point of view, looking on the predictability of the process. And in the critical size defect, so when the walls are reduced, the distance are increased, the use of autogenous bone is strongly indicated, because it's the only way that we have to bring in a predictable manner the new BMPs in the area to support the biological process. When you are using autogenous bone, you are not changing the biology behind the bone formation, but you are just improving the speed of bone formation, and you are improving the predictability of the 3-dimensional bone formation. So anytime we have a critical size defect, then the quantity of autogenous bone will be improved. And as you can see in cases like this, even we are missing a part of the walls of the defect, meaning that we have no walls, we have no source of new bone formation, and the only way to bring a biological information in this environment is to improve the quantity of autogenous bone. And the literature indicating us the positive effect of autogenous bone presence, not just in the defect management, but even in the osseointegration process of the implants. Also in the implants osseointegration process, we have a small defect that need to be regenerated, and is the space between the threads of the implant and the recipient side. It's like a sort of very small GBR with a titanium chamber. And as this paper indicates, but there's a lot of other papers indicating this, when we have a bone chips in that area, this bone chips is going to be demineralized by the inflammatory phase, and the demineralization will release the BMPs in that area. So when the blood vessels is coming to revascularize that area, the BMPs will affect the mesenchymal cells, the perivascular cells differentiation, improving the bone formation in that area, and improve the speed of bone formation close to the implant surface. And if we are missing these bone particles, the bone will grow strictly and relatively slowly from the walls to the defect towards the middle of the defect, or towards the periphery, that in this case is the implant surface. And this has been demonstrated also in randomized controlled clinical trial in the sinus, where autogenous bone was performing more, is performing much better compared to homologous bone or synthetic or bovine bone. So in the sinus, which is a very high predictable environment, the bone formation is working much better if you have autogenous bone as a graft material. So the message is not that we should use autogenous bone in the sinus, but the message is that even in a 5 walls defect, very high predictable in terms of regeneration, autogenous bone is able to make a difference in terms of new bone formation. And if the defect is a critical size defect, then autogenous bone will be the best material to support the new bone formation. But one important point is, must be underlined, that the quantity of autogenous bone in the mixture must be considered. This study testing just or studying or analyzing the mixture of 50% bovine bone, 50% autogenous bone, and 80% bovine bone and 20% bovine bone indicates clearly that what we are thinking of a graft, when we are thinking 50% of one, 50% of the other is making 100% of my graft, at the end is not like that. 60% of my graft will be based on the coagulum. And then 40% will be based on the material I'm placing together with the coagulum. So if I have a mixture 50-50, I have around 20% of autogenous bone in that mixture. And if I'm working with a 80-20 relationship between bovine bone and autogenous bone will be less than 8%. So the quantity of autogenous bone can be really minimal or more critical of what we are surgically thinking. And to have the final result or the biological result of adding autogenous bone, we need high percentages of autogenous bone in the mixture. So meaning that when a defect is very critical, we should look to 60 to 100% of autogenous bone. And if the defect is less critical, then we can reduce, and in some cases we can also avoid to use autogenous bone, because the predictability in regeneration is given by the walls of the defect, the environment of the defect itself. But we have to remember that more autogenous bone you are placing, more quality of tissue you are obtaining, and this is the result again of a randomized controlled trial. It means that we have more osteoid lines, meaning that more areas where the new bone is going to be formed, and we have more osteocytes, meaning that we have more vital tissue. And having more osteocytes, have I previously said, it means that bone will be much more able to renew itself in relation to the function that is going to receive during his life. So cells, more quality, it means more cells, and more quality we can obtain by improving the quantity of the autogenous bone. So autogenous bone in critical size defect is amazing because can really improve the predictability in a very short time frame. In this case, this approach is following the Curie technique. So we are using these thinned cortical lamina to rebuild like a sort of environment, mechanically stable environment, where particulated material is going to be inserted, and this particulated material is going to represent more than 90% of the structure of the graft material. And then a second lamina is going to be placed laterally, and no lamina is going to be placed in this case on the lingual side. But this environment will allow vascular support from the neighboring area from the soft tissue and hard tissue will allow to support the bone formation, not just from the walls of the defect, but from each area of these bone particles. And after 4 months, you see a perfect regenerated crest where we can place our implants in the perfect position. So we can really change the way we are supporting the biological process by increasing the quantity of autogenous bone. And unluckily, autogenous bone is the only material right now that help us to replicate in a very predictable way this type of result. If we are reducing the quantity of autogenous bone, we must think to place a membrane, because the membrane has not going to have just a mechanical effect, but the membrane we have seen by papers, for example, from Turri in 2016, has a biological meaning, increasing the concentration of the bone growth factors in the defect area. So we have a positive effect by placing a membrane, because the quantity of the growth factor will be much more concentrated and much more on a distance compared to the walls of the defect. So then we may have negative effect from a vascular point of view, but I think that as looking on the data from the literature, the big cutoff in terms of the defect dimension or where the vascular support can change is the 5 millimeters in the vertical direction, meaning that when you are growing more than 5 millimeters, then the lack of vascular support from the soft tissue may be a problem, as seen by the paper by Istvan Urban, but while less than 5 millimeters in the vertical dimension is not to affect too much the vascular network formation, meaning that also the vascular network formation from the only the bone side seems to be quite sufficient in regenerating the bone. So what about the other factors, the mechanical factors? How a surgical choice can affect the mechanical factors? Now, first of all, we should understand what is the meaning of the mechanical factors. And we know very well when we are talking about stability and strain resistance if we are in an implant environment, meaning that we are placing the implant, we are changing our drill process based on the quality of the bone, and we know and we are checking on our implant motor, which is the stability of the implant. And why we are doing this? We are doing this because we know that the primary stability of the implant is going to influence the microenvironment between the bone and the implant. And the stability of having a high stability of the implant is going not to guarantee directly the osseointegration of the process, but is representing a sort of risk factor. So if you have high implant stability, the risk that mechanical instability will bring to fiber integration of the implant is low. On the opposite, if you have a low primary stability, then the risk that the mechanical factors are influencing negatively the osseointegration process will be higher. It doesn't mean that that an implant with a 2 Newton-centimeter stability is not going to be osseointegrated. Can be osseointegrated, obviously, but the risk that a minimal amount of mechanical disturbances impact negatively on the osseointegration process is very strong. And why is so important? It's so important because we know from many studies performed more than 30 years ago by Bransky that magnitude of strain more than 30% are going to reduce the level of bone formation. Or even from a biological point of view, if you have too much strain, meaning micromotion or changing dimension of the coagulum firstly and provisional matrix secondly, the differentiation of the osteoblast cannot be allowed by gene expression. So we know that low level of strain is important for the osseointegration of the implants, and we should think that this element is exactly the same when we are talking about the graft material. Macrostability and strain are strongly influencing the final result of the regeneration. And now I'm going to stop at these slides.